Dr. Christopher Tarolli is a neurological educator and is the co-director of the Mind, Brain, and Behavior Neuroscience course at the University of Rochester School of Medicine and Dentistry. He completed his internship in internal medicine and residency in neurology at the University of Rochester Medical Center and graduated in 2016. He then completed a fellowship in movement disorders and experimental therapeutics of neurological disease in 2018. He joined the faculty in 2018 and specializes in the care of individuals with Parkinson's, atypical Parkinsonian syndromes, and Huntington's disease. Beyond clinical work, Dr. Tarolli is involved in clinical research focusing on novel technologies, practice-based research, and palliative care in individuals with Parkinson's and other movement disorders. Welcome, Dr. Tarolli. Thank you so much for being here. And if you want to share your screen, you can, or if something, oh, you got it. Okay.
Does that look good? All right,
that looks
perfect.
Great.
I'm gonna start my slideshow. Still looks good?
Yep.
Excellent. Okay. Well, thank you so much for the kind introduction. I am really excited to be here with all of you today. I wish we could be doing this in person, but I think you are still able to get a lot of really great information about Parkinson's today. And I just really want to say thank you to Davis and to the entire Davis Phinney Foundation for having me today. I think a lot of the work that they do is so great, and really is the advocacy that they do for this disease is really incredible. As was mentioned, I'm going to be talking today about the non-motor symptoms of Parkinson's. And before we get started, before this starts going into the chat, I will answer the question that's on all of your minds. Yes, I am old enough to be a doctor, so please rest assured about that. All right, just a few disclosures here. Nothing really relevant to what I'll be talking about today. This is just where I get some of the funding for the research that I do. And I'll just briefly, again, introduce myself. You heard a little bit about my background and where I trained. I just want to talk a little bit about how I got into this field of Parkinson's and how I got to be doing what I'm doing today. So I really fell in love with the management of Parkinson's while I was in my residency. And as I was going through that, I recognized that there were a lot of gaps in the care of how we were providing care to patients with Parkinson's, particularly on the side of quality of life. And so where I've really focused a lot of my clinical work as well as my research is on how can we improve and optimize quality of life among patients with Parkinson's. And that's really where I focus, and that's really relevant to a lot of what I'm going to talk about today, because as I'll show, quality of life is often quite dependent on the symptoms that patients have, and it's not just the shakes. It's not just the motor symptoms that patients have. It's also what I'll talk about, which are called the non-motor symptoms. So this is just a brief outline of what I'm going to be going over today. I'll first start by really just defining what the non-motor symptoms are and talk about how those contribute to disease burden and potentially reducing quality of life among patients with Parkinson's. And then I'll talk about a few specific non-motor symptoms. First, focusing on pain, a drastically under-recognized symptom in Parkinson's, and then talking about a group of symptoms called the autonomic symptoms in Parkinson's after. I mentioned before that one of the reasons I got into this field was that I recognized that there was a gap in our ability to identify these symptoms and to appropriately manage them. And so in the last part of the talk, I'll be mentioning what some of those barriers are and what I can be doing as a physician and what all of you as a person with Parkinson's or a loved one of someone with Parkinson's can be doing to manage these non-motor symptoms. And over the entire talk, I'll be talking about some action steps that you can take, and we'll go back and just review those at the end. So with that, let's actually talk about these non-motor symptoms. Now, the slide is blank right now for a reason. That's because if I mention this idea of the non-motor symptoms of Parkinson's, that must also mean that there are motor symptoms of Parkinson's. And when we talk about the motor symptoms of Parkinson's, those are the symptoms that most people think about when they hear the word Parkinson's. Tremor, stiffness, slowness, changes in walking or balance difficulties. Those are, again, what we call the motor symptoms. But as I'm sure everyone out there is aware, that is really just the tip of the iceberg in Parkinson's. And the reality is there are a number of other symptoms that come along with the disease, what we call the non-motor symptoms. I'm not going to talk about all of these in any extreme detail. You actually just heard from Dr. Pontone about some of the neuropsychiatric and cognitive symptoms that can come along with Parkinson's. But this slide is really just to highlight the extreme heterogeneity and diversity of symptoms that can come along with the disease. Everything from mood symptoms, which you just heard about, to changes in sleep, changes in your ability to smell, and again, changes in your autonomic nervous system. Now, as I mentioned, the motor symptoms that we hear about are really just the tip of the iceberg in patients with Parkinson's. And unfortunately, that's where we end up focusing a lot of our clinical time and unfortunately a lot of our research. And there's a couple reasons for this. First of all, the motor symptoms are the ones that are visual, right? I can look at a patient with Parkinson's and I can see their tremor. I can see that they're slow. I can see that they're having difficulty walking. But what's underneath the surface, those non-motor symptoms that are invisible, are often the more impactful symptoms. Things like sleep disorders, changes in speech, those neuropsychiatric symptoms that you just heard about. And unfortunately, our clinicians and many of our medications that we have really focus primarily on the motor symptoms and don't do quite enough to address these non-motor symptoms. This is just another slide illustrating how these symptoms, how all of the symptoms of Parkinson's accumulate over the course of the condition. And what you can see on here, just to orient everybody, the x-axis is time. On top, these purple triangles and purple circles are the motor symptoms that develop over the course of the disease. And on the bottom, in greenish blue, are the non-motor symptoms that develop in the course of the disease. Now, a couple important things to note here. The first thing that I'll show is that notice that motor symptoms start around here, but notice that for months or even potentially years before that, patients will have non-motor symptoms. These are what we call the premotor symptoms of Parkinson's, things like acting out your dreams overnight, late life onset depression or anxiety, or the development of constipation or changes in bowel movement frequency. So important to note that these non-motor symptoms are actually starting before the onset of the motor symptoms. The other thing to notice on this slide is that you can see the size of this triangle in each of these different stages of the disease is indicating how much burden is being caused by those symptoms. And so what you can see is that it's not just the motor symptoms, not just the tremor, the stiffness, the slowness, the walking problems that cause burden, that impact quality of life in patients with Parkinson's, but actually probably more so the non-motor symptoms that do so. You can see that those accumulate as the disease progresses and substantially can contribute to burden in the disease. And so the big takeaway that I want you to get from this slide is that non-motor symptoms are extremely common, that they start before the onset of motor symptoms in Parkinson's, and that they can have a major impact on quality of life for patients. So again, I said I'm not going to talk about each of these. Where I really want to focus my talk is on a specific somatic symptom, meaning a bodily symptom, specifically focusing on pain, and then on the autonomic symptoms, which are essentially the way that Parkinson's affects your gastrointestinal system, your stomach and intestines, your cardiovascular system, so your blood pressure and heart rate, and your genitourinary system, so your ability to urinate or have appropriate sexual function. And that's where we're going to focus the majority of the rest of the talk. So let's talk about pain in Parkinson's. Now, I mentioned in my intro that pain is something that is incredibly under-recognized. And the reason I say that is for two reasons. Number one, pain is extremely common in Parkinson's. This graph, I don't want you to focus too much on the details here. I just really want you to focus on this first set of bars. This is showing persons with Parkinson's. You can see those with early stage disease are in dark gray, late stage disease are in lighter gray here. And what you'll notice is the group of patients who have no pain is only about a quarter of each of those populations, which means that 75% of people with Parkinson's, no matter where they are along the course of their disease, are going to have some pain. Pain is extremely common. And again, I think one of the reasons that it's under-recognized is that this is not something that's taught. You heard about my background. I had 4 years of training in general neurology, 2 years of training, subspecialty training in Parkinson's and other movement disorders, and I never learned this anywhere in my training. This is something that I found as I've continued to be in practice over the past couple of years. And so this is something that we need to really increase the recognition of, that pain is extremely common in Parkinson's. Now, I think the reason it's probably not so well taught is because pain can come from many different sources among patients with Parkinson's. The first, and probably the most common, is something that is not specific to Parkinson's at all, the idea of orthopedic issues. There's no reason a person with Parkinson's can't have arthritis in their hips or their shoulders or their knees, and that can certainly contribute to pain. But portions of the disease itself can also contribute here. So muscle stiffness, what we call the formal name for that being rigidity, can certainly cause pain among patients. And so it's actually Parkinson's itself that can contribute here. As many of you know, many patients with Parkinson's will develop abnormal posture. They might have a stooped posture starting to lean forward as the disease progresses. That's going to put additional stress on the musculoskeletal system, and if you already have orthopedic issues, you might adapt to that change in posture with some what we call maladaptive techniques, things where you actually put more stress on your arthritic knee or hip. And this ends up being, unfortunately, a bit of a negative feedback loop where each of these things ends up worsening each other. There's another motor symptom that I'll mention, something called dystonia, that can certainly cause pain. This is an abnormal, sustained muscle contraction. The most common form of this is going to be some curling of the toes, and again, sometimes that can be painful among patients with Parkinson's. And then finally, probably one of the less common, but certainly seen causes of pain among those with Parkinson's is something we call nerve pain. And we don't really have a great idea of why this happens in Parkinson's as opposed to why it happens in other diseases, but we certainly see it. Now, the reason I think this is important is because pain not only has its own direct effect on disease burden and direct effect on quality of life, but it also feeds back and has a negative impact on almost every other symptom that patients have. Patients with uncontrolled pain often have worse control of their motor symptoms. They aren't able to have as good of tremor control. They aren't able to control their slowness as well. It's also going to feed back on a lot of those symptoms that Dr. Pontone mentioned. Depression, anxiety, cognitive symptoms can definitely be worsened in patients who have a lot of pain. And so the reality is we really need to be proactive about identifying this and managing it to stop that negative feedback loop. So how can we do that? What are the strategies we can use to manage pain among those with Parkinson's? Well, the first thing to do is, I mentioned there's lots of different causes of pain. And so the first thing that we need to do is identify why the patient is having pain, because the treatments are going to obviously differ substantially. That being said, staying active, regular exercise is almost certainly the most effective strategy that people can use to manage pain, no matter the etiology. And so whenever my patients are coming in and talking to me about the pain that they have, one of the first things that we talk about is their activity. How are they able to exercise? And what we know is that staying active can help to reduce pain and prevent the eventual development of pain among those with Parkinson's, and probably outside Parkinson's as well. Now, this sometimes becomes a catch-22, right? I have a number of patients who come to me and say, Dr. Tarolli, you're telling me to be active, but I am in so much pain that I cannot get out there and be active. And that's really where I often will utilize my physical therapy colleagues who can help patients to develop a graded exercise program where they can actually slowly integrate more and more exercises into their regimen to, again, feed back and help to manage that pain. I mentioned before that one of the causes of pain can be incomplete or non-optimal motor symptom management, right? The stiffness of Parkinson's and that symptom of dystonia, those can come if patients are having a lot of off time, their medications are wearing off, and you can actually see pain in the setting of dyskinesias, those extra wriggly movements that some people get as well. And so one of the key things that I focus on, if I identify that as an etiology of pain, I make sure that we're optimizing a patient's motor symptom management, changing their Parkinson's medication in order to make sure that their management is optimized. And then finally, if we've done all of these things and pain remains an issue, we can consider medications that can address the specific type of pain that that patient is experiencing. And I'm not going to talk a lot about those right now because there's quite a bit of heterogeneity among those. So the key point here, the key point that I want you to take home with pain in Parkinson's is that pain is extremely common, and one of the most effective ways to manage that is with regular exercise and activity. All right, let's shift gears now and talk a little bit about the autonomic symptoms in Parkinson's. And I recognize Most of you are sitting out there and saying, I have no idea what this guy is talking about. I've never heard this term autonomic symptoms. So let me first provide a definition for you. Autonomic symptoms refer to dysfunction of a part of our nervous system called the autonomic nervous system. And this is the part of our nervous system, the unconscious portion of our nervous system, that controls all of our bodily functions. And what do I mean when I say bodily functions? Well, this means our cardiovascular system, our ability to regulate our blood pressure and our heart rate. This refers to our gastrointestinal system, the ability for us to move food and liquids through our stomach and our intestines, and our genitourinary system, which, as I mentioned before, really refers to our ability to have appropriate sexual function and to be able to urinate. And the autonomic nervous system can, just like many other parts of the nervous system, can be affected among those with Parkinson's. Now, I'm not going to talk about dysfunction in each of these. I really want to focus the rest of this discussion about a specific dysfunction within the cardiovascular system that's called orthostatic hypotension. So I'm going to read the formal definition of what I mean when I say orthostatic hypotension here, but I promise I will give you a much easier to understand definition after that. So orthostatic hypotension is low blood pressure that occurs when someone sits or stands up that causes reduced blood flow to the brain secondary to those changes in the position. So basically what this is drops in blood pressure when someone sits or stands. And again, what ends up happening is if your blood pressure drops, that means you don't have enough blood pressure to push the blood up to your brain, and that's going to cause symptoms. Now, most of us, whether or not we have Parkinson's or not, have experienced this at some point and have experienced mild forms of these drops in blood pressure. But the symptoms that we can see can become much more severe if this is something that becomes more consistent or more long-standing. So most of us are familiar with this sense of a head rush or this idea of lightheadedness when our blood pressure suddenly goes down, but most of us are able to quickly bring that blood pressure up to stop us from developing other symptoms. So the first symptom that we see with orthostatic hypotension is this idea of lightheadedness or that head rush sensation. This can obviously progress to be more severe. Patients can actually pass out or faint because they're not getting enough blood to their brain. And if this is something that's happening over a longer period of time, patients can develop other symptoms that basically stay with them, that don't go away after just a few seconds of them standing. They might feel really nauseated or vomit. They might have a sense of fatigue because they're just not getting quite enough blood to their brain, and they might describe something like clouded thinking. All of these symptoms can be associated with orthostatic hypotension, and so it's really important for us to identify this and try to manage it as best we can. Now, the question that I often get is, why is this happening? And there's a couple reasons. The first, as I mentioned, is that Parkinson's itself affects the autonomic nervous system. So Parkinson's causes a person's body to have a decreased ability to raise their blood pressure in response to them standing up. But the reality is it's often not just Parkinson's that we see causing orthostatic hypotension in our patients. It's often Parkinson's plus some side effect of a medication. Most patients with Parkinson's, most patients over the age of 60 are probably on some type of blood pressure medication. And blood pressure medications, what is their goal? Well, their goal is to drop your blood pressure. And so if you have a condition that causes your blood pressure to drop too much, and you're on a medication that causes your blood pressure to drop more, that can obviously worsen that symptom. And so I'll often work with internists, general practitioners, cardiologists, in order to find the way to reduce the dose of this medication as best we can to reduce these symptoms. I want to also point out that it's not just dedicated blood pressure medications that can do this, but there are actually some medications for Parkinson's that can do this as well. The main culprit being what are called the dopamine agonists. So these are medications like pramipexole, also known as Mirapex, ropinirole, also known as Requip, or rotigotine, which is often administered as a patch. These are going to be the biggest culprits among the Parkinson's medications that can actually cause a direct drop in blood pressure. But carbidopa-levodopa are most effective, generally best tolerated, and it can also do this as well, though it's going to be less common to do that than the dopamine agonists. So what can patients do, or what can I recommend to patients if they're experiencing orthostatic hypotension? Well, the first thing that we always want to do is think about non-pharmacologic, non-medication strategies to stop this from happening. And the first is certainly the easiest, is having patients stand slowly. So if you're lying down in bed, you're asleep for quite a few hours overnight, and you sit up in the morning, I tell my patients wait 2, 3, maybe 5 minutes on the edge of the bed before you stand up. This allows the autonomic nervous system to get used to the idea that you're sitting, and so there isn't quite as drastic of a drop in the blood pressure. I also tell people to increase their fluid intake, but it's really key that it not just be an increase in water intake, but also to increase salt intake. So this can mean you can drink Gatorade, which has a lot of electrolytes in it, or I actually end up telling my patients to feel pretty liberal to take in things like potato chips or pretzels or other high salt containing foods, as long as that's safe from their internist perspective. And the reason for that is if you just take more water in, your kidneys essentially just pee out all of that water, and it has not really much of an effect. By taking water with salt, it keeps more of that fluid inside your vascular system, and it allows you to maintain your blood pressure higher. Another way that we can do that is by wearing compression socks. So a lot of patients will have some pooling of blood in the veins in their legs. And so compression socks, these really tight stockings, basically push the blood out of the legs, push it back to the heart, and keep more of the blood on the arterial side of the circulation so that the blood pressure can stay up. And then the final thing that you can do from a behavioral or lifestyle intervention is elevating the head of your bed. So here we have a bed. And what I recommend my patients do is actually put a small brick under the feet of the bed exclusively at the head of the bed. So it's going to look something like this, raising that head of the bed anywhere from maybe 3 to 8 inches. And what this essentially does is rather than lying completely flat when you're asleep at night, it sort of tricks your body that you're sleeping in a slightly more upright position. Now, a lot of people ask me, do I need to do it this way? Do I need to do it with a bed lift, or can I just use something like a wedge pillow, which props my head up? What we've seen in research is that a wedge pillow is not as effective. For whatever reason, we need to have the feet being in the same direction, the same axis, the same line as the entire rest of the body, so it does need to be done this way, and I generally recommend patients raise it anywhere from 3 to 5 inches. I have heard that if you're raising it much higher than that, it can kind of be uncomfortable and feel like you're slipping out of the bed. So again, those are non-pharmacologic interventions that we can use to manage orthostatic hypotension. We can also use some medical interventions to do this. The first and the simplest being thinking about those medications that can worsen this symptom that I mentioned on the last slide. Blood pressure lowering medications, or potentially some of those Parkinson's medications, and doing our best to either avoid or reduce those medications to the lowest level that someone can be on to decrease that drastic effect on blood pressure. Now, if we've done all of these things, we've instituted all of these lifestyle interventions and we've reduced medications as much as we can, that's really then where we start to rely on medications to actually artificially increase the blood pressure. And there's 3 main medications that we focus on. This one called fludrocortisone or Florinef, another one called midodrine, and then actually the only FDA-approved medication for orthostatic hypotension in the setting of Parkinson's, a medication called droxidopa. Again, we use these if we haven't been able to control orthostatic hypotension in patients who have tried these other interventions. And just the one thing that I want to mention about these is because we're artificially increasing someone's blood pressure, we do actually need to monitor people's blood pressure while they're lying down, because it can actually increase their blood pressure and give them hypertension, excessive blood pressure, when they're lying down. So usually when I have someone start these, I'll have them get a portable blood pressure cuff and just check their blood pressure for the first few weeks while they're lying down at home. So key takeaways here on the autonomic nervous system and orthostatic hypotension is that there are really simple lifestyle interventions that you can take to help to manage these bothersome drops in your blood pressure. All right, I'm going to finish with just a brief discussion of some of the barriers that we have to identifying these non-motor symptoms in clinical practice, and also giving you hopefully some action that you can take to actually manage these better. So we're going to talk about sort of 3 different aspects of barriers. The first are going to be the physician level barriers. So these include things like the physician frequently wanting to focus on managing the motor symptoms. And that comes from a couple of reasons. Number one, we've traditionally thought about Parkinson's as being a motor symptom disorder. Number two, those are the most visible symptoms, as I mentioned. And number three, those are the symptoms that I am not only most able to treat because of the availability of medication, but also the symptoms that I am most comfortable treating as a physician. So we end up focusing, unfortunately, on these motor symptoms. The flip side of that is that many physicians are actually uncomfortable or less comfortable managing some of these non-motor symptoms. I'll be honest, I feel reasonably comfortable offering a first-line medication for the management of some of the urinary symptoms that we can see with Parkinson's. But once we get beyond that, if I'm not successful, I'm really out of my comfort zone. And you can imagine neurologists out there or even general practitioners out there who don't have as much subspecialty training as I do are going to feel even less comfortable managing these diverse non-motor symptoms, and again, push them to focus on managing the motor symptoms in their practice. And then finally, this is probably a physician and systems barrier, but we have a limited amount of time with patients. And there's a huge diversity of symptoms that we could talk about in a visit, but because of all of these other problems that I've mentioned, we end up focusing this limited amount of time on the motor symptoms commonly. Now, there's also patient-sided barriers that we have here. The first is that many patients are simply unaware of what symptoms are relevant, right? I showed that huge list of what could be included in the non-motor symptoms, and I said those are part of Parkinson's themselves. Most patients aren't aware of that, and so educating yourself about the relevant symptoms, the common symptoms of Parkinson's, what you should be talking to your physician about is really important. Many of these symptoms are also episodic. They come for a period of a couple of weeks or even maybe just a couple of hours a day. And while they may be very impactful at the time that the patient is having it, if you're only seeing your physician every 3, 4, 6 months, by the time you go back in to see them, that might not be the thing that's on top of your mind. And then finally, there's actually some symptoms of Parkinson's that reduce a patient's ability to either be aware of their symptoms or actually reduce their motivation to bring those symptoms up. These ideas of apathy and unawareness of symptoms that we can associate with the disease. Finally, there are systemic barriers that we have that really also impact our ability to identify these non-motor symptoms. So I sort of mentioned this one before, but really almost all of our medical interventions where we have FDA approval for a medication, almost all of them are on the motor side. We really don't have great data on the management of non-motor symptoms in Parkinson's except in a few very specific circumstances. And then the other thing, this kind of gets back to this idea of a limited amount of time with patients. Unfortunately, we don't have a great systemic, proactive evaluation that can screen for all of these symptoms ahead of time to make sure that we're identifying the things that are most impactful. So what is it that you can do in identifying these symptoms and taking control of your care? Well, the first thing that I tell all of my patients to do is to write down their symptoms. This prevents you from forgetting your episodic symptoms, and it allows you to prioritize what you want to discuss in your visit. It stops that natural tendency from focusing the visit on the motor symptoms. Educate yourselves. You're all here today, so you're already doing this, but make sure you know what are the relevant symptoms in Parkinson's. What are the things that are related to this disease? And then I always encourage my patients with Parkinson's to engage their loved ones to account for some of these other symptoms that reduce their own ability to provide some of these symptoms. Make sure that you have advocates there with you. Engage them in your care. And so the big takeaway here is that I want you to be aware of your common non-motor symptoms and that you should be going into your visit highlighting your priorities, those things that are having the most impact on your quality of life. All right, that's the majority of what I wanted to say. Let's just go back now and talk about what I want all of you to do to take action here. So big takeaway points and action steps. Again, remember non-motor symptoms are common. They accumulate with disease progression, and they can have a major impact on quality of life, probably an outsized impact even compared to the motor symptoms. Remember, pain is extremely common in Parkinson's, that it can impact almost every other symptom that patients have, and that activity can help to manage pain no matter the etiology, no matter the cause. Remember, there are simple lifestyle interventions if patients are experiencing orthostatic hypotension to stop those bothersome drops in blood pressure. And again, when you go into your visit with your provider, be aware of these most common non-motor symptoms, educate yourselves, highlight your priorities, and have your advocates there with you to help you to advocate for yourself.